All right. Thanks everyone for being here. We are very excited to have you here for our final Department of Medicine Grand Rounds for the year. And we are even more excited to be joined today by Dr. Alsan, leading us into the end of 2024 with our final Grand Rounds. Dr. Alsan is a physician economist studying the economics of health inequality domestically and internationally. She received her BA from Harvard University, a master's in public health from Harvard School of Public Health, her medical degree from Loyola, and a PhD in economics from Harvard as well. She trained at Brigham and Women's Hospital, Howard Hyatt Global Health Equity Residency Fellowship, then combined her PhD with an infectious disease fellowship at MGH. Prior to returning to Harvard, she was tenured at Stanford. She's an associate editor at the Journal of Economic Literature and co-chair for the Healthcare Delivery Initiative of the Abdul Latif Jameel Poverty Action Lab at MIT. She's a recipient of a MacArthur Fellowship and was elected to the National Academy of Medicine in 2022. She co-directs the Health Inequality Lab at Harvard Kennedy School of Government. And we are very excited to have her here today with us. Thank you for joining us today, Dr. Alsan.
Thank you so much for having me. I really appreciate this opportunity. This is joint work with a really terrific grad student, Yusra. And our topic is, why doesn't the United States have national health insurance? The role of the American Medical Association. I'm kind of used to being interrupted. The economist in me is often interrupted. So please feel free to just interrupt me verbally. I might not see the chat, and then I'll try and leave some time at the end, at the last 10 minutes or so, for 5 to 10 minutes for questions. So our starting point for this was just that the US is exceptional when it comes to health. We spend more on healthcare than any other country, about one out of every $5 of our GDP. And that's about $5,000 more than our nearest neighbor, which tends to be, in most surveys, Switzerland. There was a debate, obviously expenditure is P's times Q's, so it's prices times quantity. Maybe the average American is just getting a bigger bundle of goods for that extra expenditure. That does not appear to be the case. Time after time, it actually appears that Americans just are paying higher prices for a similar basket of goods, of health and medical products. The other Q, of course, is quality. Maybe the quality that Americans experience from the healthcare sector is just so much higher than other developed countries. But in fact, if you take a step back and look at the population level, and there's a really great Commonwealth Foundation puts out a really great publication on this every year. The U.S. tends to do worse on population health metrics, including those that you might think would be amenable to medical practice. And I think if you're interested in equity or the distribution of outcomes like I am, that for average is driven by striking heterogeneity. So this is just one example. I'm sure in Atlanta, Georgia, you're experiencing some of this. On the right-hand side, this is from that Commonwealth Foundation comparison. It's called Mirror Mirror, if you're interested in looking it up. And this is maternal mortality rates in the US compared to peer nations, showing that orange outlier. And then on the left is from Kaiser Family Foundation, showing that striking heterogeneity across racial and ethnic groups. You could also, if the data were available, do it by education or class. And you would see that the incidence of this is falling on those who are Black American mothers. What's also interesting, though, is that we're striking in the way that we organize our healthcare system. So there's many different ways of looking at this. This is actually my favorite health economist, is now deceased, Uwe Reinhardt out of Princeton, mapping the flow of funds in the US healthcare in 2011, just showing the complexity. So we have a very large role, as you know, for the federal and state and local government in healthcare spending. But we also have a very large private sector. And in fact, still people are paying, either they're uninsured or underinsured, they're paying out of pocket. When Reinhardt then mapped the value chain in 2019, you can see all of the individuals who are really employed in this healthcare sector, many of which are non-clinical, and even don't even have like acronyms that would be fit in other countries, for example, PBMs, and so on. So the key theme though is that we're not necessarily, not government subsidized. We're heavily government subsidized. We're not necessarily fully private. We're some complex amalgamation of both. And I think despite this past decade or more now of reform, um, still Americans are uninsured, underinsured, and I think unhappy with a lot of what they're experiencing in terms of their healthcare coverage. Um, and for the first time, I think in at least my experience as a health economist, prominent health economists are actually coming out and pointing to the healthcare system as a reason for these population health statistics. Like oftentimes the focus has been on cost or price, but now they're really focusing on outcomes. And they're not doing this in what would be considered canonical economic publications, peer-reviewed research articles. They're doing it more in books or in review articles. And this is just a snapshot of what you might have seen on the bookshelf or on Amazon. This project actually takes a step back and wants to understand how we actually got here. So from leading economists Angus Deaton and Ann Case out of Princeton, they call it a historical accident by which most Americans are covered through employers is a huge source of difficulty and a barrier to reform because, of course, employer-sponsored coverage or private health insurance or commercial insurance, whatever it might be called, that is still is the majority of ways Americans, about 60%, receive their health care. Blue Cross Blue Shield, writing in 1997, their fact sheet says it was really American industry being very strong, converting from a wartime to a peacetime economy, and the strength of unions who included these types of benefits in their package. And of course, the tax exemptions that finally we all probably on the Zoom room take advantage of in order to pay a private company in many instances or a nonprofit company for this service without facing additional taxes. And then finally, Ina and Finkelstein, two of the economists that wrote "We've Got You Covered," this recent popular press book, wrote, "There's a popular narrative that the U.S. never had a chance at achieving universal coverage, that we lacked a labor union a movement strong enough to push for it." So that's exactly the opposite of what Blue Cross Blue Shield says, that we face strong opposition from the American Medical Association, or maybe it's just in our DNA. It's just our culture. We're rugged, individualists. We would never ever stand for a national health insurance program. And in fact, when I asked ChatGPT, as the kids do these days, this strong tradition of individualism and this market-driven approach that's really culturally ingrained came out very, very strong as a primary motivation for why the U.S. lacks a national health insurance system. So what we do in this paper is we take seriously the hypothesis that the AMA played a role. So we explore whether and to what extent an interest group, namely the American Medical Association or the AMA, contracting with the very first political public relation firm known as Whitaker and Baxter out of California, defeated what we consider here in the government, in the School of Government, a key component of social insurance. So you've got your unemployment insurance, disability insurance, old age security, and health insurance. All are to guard against the loss of income. And this is one component that we just don't have in the US. Now, the campaign focused on what's known as indirect lobbying. So you might know about direct lobbying. Those are the quid pro quos, the backdoor deals, sliding money under the door, et cetera. But indirect lobbying is actually trying to influence the congressperson by going through the electorate. So you go through the electorate in order to get your policy passed. And how did the AMA do this, or how did Whitaker and Baxter do this? They did it by framing health insurance as an ideological issue, associating anything that was national with socialism and communism. But they also did another tactic, which was incredibly effective, which was both to create and then enroll the American public in private health insurance schemes. This is what we now call Blue Shield or Blue Cross Blue Shield. So they created those. The doctors, our heirs, our ancestors rather. And they did this because they wanted to defeat these legislative efforts, not just in the short run, but also in the long run. Now, how do we know this? We know it because they actually wrote it down. So this is Whitaker and Baxter. They were the owners and the founders of Campaigns Inc., this PR firm. And here they are outlining their strategy to the American Medical Association. They say the immediate objective is the defeat of compulsory health insurance or national health insurance, depending on your terms, in Congress, which is right now. And there's great urgency to that phase of the problem. But the long-term objective is to put a permanent stop to the agitation, or as an economist, I might say demand, for compulsory or national health insurance. And the most vital step in achieving that objective will be an all-out campaign to enroll the American people in voluntary or private health insurance systems. So this is what we do. We try and study this campaign and try and understand whether it was effective. We wouldn't have been able to do this project 10 years ago. Why? Because most of our data, in fact, the lion's share of our data, comes from these archives of the private PR firm. So this firm, Whitaker and Baxter, they were actually married. They had a family. This was a family business. Their son, Clem Whitaker Jr., ran it for a little bit. Then, after his parents passed away in the late 90s, early 2000s, he actually decided to stop running the business a little bit after that and gave all of the firm archives to the state of California, where this company was based. So that actually, they have hundreds and hundreds of boxes detailing this campaign that they ran for the AMA, which was their biggest campaign. AMA was one of the biggest interest groups that, as far as I understand, that really has ever existed in American politics. Now, the other thing was machine learning and being able to unlock text at scale. So now we can OCR all of this in sort of record time and really use these data in our analysis. We have other archives. We have Gallup polls. We went to the AMA. I'm an AMA member. I have been since I was an AMSA member. And so we were there too. There was very little written. We couldn't find anything in the AMA archives about Whitaker and Baxter. But there were other pieces, including the Blue Shield insurance enrollment, which is also really important. And so what we're able to do then is reconstruct exposure to this campaign, and I'll describe it in more detail in a few minutes, and then see how it affects actually voter preferences through Gallup poll questions, and then actually how it affected enrollment in private health insurance, which was one of the key outcomes. We're also going to look at, as you may know, we're looking at the post-World War II period. We're looking at the Truman administration and their full-throated attempt to pass this legislation. It never actually left committee. So how do you actually try and discern whether or not this had an impact on the congressional process? So for that, also using OCR and machine learning techniques, we can look at how the congressional leaders were talking about health insurance. And we can actually compare, using something called cosine similarity, we can compare the speech patterns of the congressional Congress people to when they were speaking on the congressional floor to the AMA Whitaker-Baxter propaganda. And we can see them kind of align. So that's what we'll show you. So what do we find in a nutshell? We find that this campaign catalyzed the growth of private health insurance in the US. We'll talk in terms of one standard deviation units because it's a continuous measure of campaign exposure. It leads to about a 20% increase or 14 million new signups. It shifted public opinion. National health insurance was incredibly popular and had about 70% support in the pre-campaign period. We see that drop precipitously, 20% or 5 to 6 percentage points per wave, per Gallup wave, which is oftentimes more than once per year. And then we find these effects on political outcomes. So I'm going to kind of skip over some of this. I think there's a long literature in economics of media, about persuasion, about lobbying, et cetera. Physicians, we're a favorite subject of study for economists because obviously we have a lot of data, we make important decisions. But I think where we're trying to push the envelope a little bit here is we're talking about, not just product advertising, but political advertising, not just direct lobbying, but indirect lobbying, not just talking about, why are we such an individualistic country? Is it selection of who comes into the country? Is it our rugged frontier experience? Well, what about leveraging narratives of individualism in order to get your preferred policy stopped, thwarted, or passed. And then, what does it mean when you actually include these licensing requirements that can create, it can create rents, it can create barriers to entry, and it can create rents for physicians as in other industries. And what do they do with those extra dollars? And what happens when they use it to, in fact, shape the market in their favor? All right. So this is the roadmap for where we're going. And I think I'm speaking very fast, so I think I'm going to get through a lot of it. But yes, please do feel free to interrupt me at any time. So historical background. So a key question is, why was this an Armageddon moment? At least for our quote unquote identification strategy, which means as an economist, sometimes I use randomized trials, but sometimes I try and draw causal inference using observational data, which is the hubris in some ways of applied econometrics. But we have to kind of argue that the AMA didn't see this coming. So we're going to mention that this is like an Armageddon moment in the history of public policy. Then we're going to introduce this concept of like, what is political public relations? It was very new to us. And this was indeed the first firm that we know of to have use this as their strategy. And then, it's not entirely clear why the AMA would even oppose national health insurance. I mean, this is now a steady stream of income. Can you imagine if where doctors would be if we got rid of Medicare? So why were they fighting against it? And then we'll talk about that campaign. So very, very quickly, pre-World War II, there really wasn't such a thing as health insurance. It wouldn't, in fact, there was even a debate. Do we call it health insurance? Do we call it sickness insurance? And in fact, doctors working with the AMA, so the AMA was for it before they were against it, economists, the American Association of Labor Legislation in the progressive era, were actually trying to promote social insurance because in a post-industrial society, a key function of the state is to guard income against adverse shocks, right? So they tried to introduce state-sponsored insurance, but they were thwarted by the outbreak of World War I, and they actually made a crucial error. Aetna and MetLife were around there then providing life insurance, and they included funeral benefits in their sickness insurance. And so the large insurance companies were against it at that time, this being the large life insurance companies. The Great Depression hit, obviously, that was 1929, the crash. It led to the decimation of savings for the elderly population. So FDR's first thought was for old age security, and to do that at the federal level because we had workers' comp and we had unemployment at the state level already. And so this was another opportunity. You could not just do old age insurance, you could also do, health insurance. But for various reasons, in fact, I think he was very, very focused on the plight of the elderly at the time. He chose to focus on a more limited, Social Security tax that we all pay, a payroll tax, also now to Medicare, and started with that. So he crucially left it out of the federal 1935 Social Security Act. That didn't mean that the demand for medical insurance as it became more expensive disappeared. It just actually devolved to the state level. So states like New York and California and many, many others started to take up this idea of maybe we just passed health insurance at the state level. Except this is actually when the doctors start to organize against it. At this time now, for reasons that I'll reveal in a couple of slides, physicians, especially state medical societies, have decided that this is a threat to them setting their own prices. And for example, in California, they start the very first Blue Shield plan known as California Physician Service. And so they start to try and enroll people in these nonprofit plans, though it's not really going very well, but at least it is in name and not an alternative to state-sponsored plans. Finally, the World War II is coming to a close. FDR seems willing to embrace medical insurance, complete social insurance, and articulates this economic Bill of Rights, but he dies suddenly in office in his fourth term. His new vice president, Harry Truman, is kind of an unknown from Missouri. And in fact, he picks up the mantle of the Fair Deal, wants to complete the New Deal, and sees health insurance is the key missing component. So he draws up a plan, is kind of loses control of the Congress. But then this happens, and this is really the Armageddon that we're talking about. Shockingly, surprisingly, against all of the pundits and pollsters, Harry Truman wins. The Democrat beats Dewey. This headline is flipped. That's how much of a surprise it was. Harry Truman wins in 1948. He has control of both chambers of Congress, and so the AMA self-described as a Armageddon moment for them because they did not, like the rest of the country, really see this coming. And he's been campaigning on national health insurance. What about political PR? Well, Whitaker and Baxter, I mentioned before, this husband-wife team. He had a lot of editorial. He had a lot of editorial experience in Sacramento. She was in the Chamber of Commerce. They just saw this need. California has and still is a direct democracy state. You can vote on resolutions, propositions, recalls, and so on and so forth. And so they actually, saw that there was this vacancy where, as these progressive proposals came through, if they could kind of shape public opinion, and they could get paid handsomely for that, that would be sort of a very lucrative business proposition. So they called California the testing and burial ground of progressive politics, and we're very happy to take credit for that. And they were actually key in defeating the multiple times Governor Earl Warren tried to introduce state-sponsored health insurance in California. They also documented the success in a public relations newspaper that they sent then to all the state medical societies, including their national headquarters, the AMA's headquarters in Chicago. So that's all I'll say about them. It's just interesting to know that this is where it started. And then why did the AMA oppose national health insurance? As I mentioned, in the progressive era, they were for it before they were against it. But doctors grew incredibly powerful with the technology that came out of the wars, the two great world wars, especially when it comes to surgical techniques and anesthesia. And that's really why there also was huge changes in licensing on the heels of the Flexner report. So basically, you had fewer physicians, and they were specialized in doing many of these things. The returns to technology were driving up their wages. And this actually led to the growth of the specialties. So here, and this is kind of maybe shocking for some of you, it was for me anyway, this is just looking at how many physicians were members of the AMA. That's the purple dotted line. So between 1920 and 1950, AMA is growing from 60 to almost 70% of all physicians are members of the American Medical Association. Today, that number is about 15%. So this is really at the zenith of its power as an organization, as an interest group. And then you can also see the rise of the specialists. So now we're going from about 10% of physicians are specialists to over a third. And actually, what's also interesting is physician incomes are growing over this time relative to the average. Personal income is in green. Physicians, you can see this big jump as the technology comes on board. Their service becomes this technology is complementary to their labor input, so they're really seeing their real incomes rise relative to the American public. This, again, I did not, expect this. This is just descriptive data, but I thought that specialists earning more than, of course, ID physicians, with the exception of ID physician specialists earning more than general practitioners, was a new phenomenon. This actually goes all the way back to 1949. You can see that these specialists are not necessarily what you would think of as specialists today, but back in the 1950s, if you were just dealing with children or just dealing with adults, you were considered a specialist and earning a lot more than the average American. Finally, we can just see that the AMA started to become this very specialist dominated organization. So although on average, 70% of physicians are in the AMA, you can see it's 92% if you just condition on being in the specialty versus about 56%. So bottom line, doctors are earning more. They're benefiting, as are the public, from these technologies, which is leading to this division of labor because you can't possibly, master the corpus of the entirety of surgery and internal medicine and pediatrics, et cetera. So this natural branching off, earning additional, income associated with that technological marginal product of labor increased, and essentially not wanting to have to negotiate with the government or really anybody else when it comes to setting their wages. So there's both a profit part of this and an altruistic part of this. The profit being, look, we don't want anyone setting our prices. We'll do that ourselves. Thank you very much. And the altruistic part of it, if you will, is like, we don't want anybody telling us to do with our patients. So there are still, those are the two strong motivations, I think, for when you read the literature as to why they're so opposed at this time. Though it is interesting that the commitment to patient care has always been there, and yet the flip-flopping has been on the embracing or discouraging of NHI. So this is the campaign. You can see it's the AMA. It's called the National Education Campaign with Whitaker and Baxter as the directors. We got this from Sacramento. And there were two key components, and it ran over this period, 1948 to 1950, because that's the Armageddon period. That's when they got the new Congress in, when they have an executive who's incredibly dedicated to this issue. And there were two key parts. So there were, any good campaign needs field workers. And so that was us, that was the physicians, we were the field workers. And then there was mass advertising. And in that day, it was really through newspapers, not through social media. So physicians received over 50 million pamphlets, coupons, posters to be displayed in their offices. They referenced individualism, like they leveraged this ideological component. They referred to free choice, and national health insurance was compulsory. Socialist physicians, as I think we are today, still really looked up to in society, were well respected. They were involved with a lot of civic organizations. So they also provided template resolutions for these civic organizations to pass. They were instructed to talk to their patients about enrolling in the Blue Shield option or any other insurance plan, just get them in a private plan. In terms of the newspaper ads, these were large ad buys. They really hit hard right before the 1950 midterms. They had the same tagline. This was the tagline that kind of carried throughout all of the material: the voluntary way, which you could again read as the private sector way, is the American way. And then another thing that we discovered actually just from looking in these old newspapers was the doctors enjoyed a lot of tie-in advertising from other industries, sometimes even far away in the product space, that also did not want their prices set coming out of World War II. So here's an example of some of the pamphlets that you or I would have in our doctor's office. So the voluntary way is the American way. That's, again, one of their key taglines. These were Whitaker and Baxter designed. This very foreboding American eagle, health the American way. The one on the right says compulsory health insurance or politically controlled medicine, a threat to health, a threat to freedom, a message from your doctor. If you value your liberty, if you value the health of your family, turn inside and read this document indictment of socialized medicine. And so this was not what we would call informative advertising. There wasn't anything about who was covered or what the prices were or what the enrollment windows were. These all actually were things that the AMA developed further on, but this was all just kind of the same, really, hard hitting. Again, their main ad took up a whole newspaper page. Who runs America? Is it the Congress, the president, or you and the man next door? It's the job of all of us. We're fighting against socialism. The voluntary way is the American way. Talk to your insurance person or your doctor about enrolling in one of these plans. That's down here at the last. I don't know if it's how well it's showing up there, but paid for by the AMA. What was surprising to us was how subtle this was. So I had my research assistant. We had the actual receipts from the Whitaker and Baxter archives about where they published these ads and when, and so we were looking in the newspapers to verify that this campaign was executed as described in the archives. And she kept on picking up. She said, Dr. Alshan, I'm finding more than one ad for newspaper. And I said, Vanessa, please check your code. She was using image detection techniques in Python. She's like, no, no, really, can you please just come look? She was right, I was wrong. And so what we discovered, which was called tie-in advertising. So the AMA president had actually connected with other chambers of commerce, with the National Association of Manufacturers, and they had kind of gotten together. So this is Walgreens saying, free from pills to penicillin. This is all about American progress. Free America has no place for socialized medicine. And then you can see the voluntary way is the American way. That's the tagline. This is a state bank. And then this is just a farming implementation company. So you can imagine if you just put yourself in the shoes of it, like a typical 1948 American opening up the newspaper, not only would they see this big ad, but then there are these just subtle kind of messages peppered throughout the newspaper. So we can tell that this was very coordinated, obviously, from the history. You can also see it in sort of where the ads are. Wherever there's a main ad, this is where we typically see the tie-in ads. We typically see 3 on average of these tie-in ads. And we can also look at it by industry. So it tends to more be pharmacy and insurance, other insurance companies and medical services, but you even see things like food and finance. For example, dairy products it was very important to have the American Dental Association tell parents to have their children drink milk. And so they were very, very happy to support this campaign. So subtle things like that. So when you take this all together, you can see what the average American would have seen from these pamphlets and these ads. Obviously you're seeing something about medical and health, but you're also seeing this strong theme of America and compulsory and freedom kind of come through in this messaging. So then we started to think, is this just how everyone advertised in the 19th? Like, did you just say, communism, go buy a sweater? But in fact, that wasn't a common thing that was occurring, at least at our time. And they really pioneered this, many of these techniques, Whitaker and Baxter. But you can see that, they're in terms of using any word or the number of words, it's very, very much a feature of these AMA Whitaker Baxter ads, and it's not kind of caught on, and it's not a common thing at that time. This is the same finding in table form. We don't want to pretend like this is the only thing driving the take-up of health insurance. Incomes were rising overall in the post-World War II period, so maybe it's just medicine is a normal good, and so there was this demand. It could have been unionization. That's really what had been in my slides 2 years ago, that this was an accident of how strong labor was. So we're going to control for unionization. We're going to control for hospitals and Blue Cross. Blue Cross has a separate history, very kind of actually distress-related beginnings, as opposed to Blue Shield, which is coming from a more advantageous financial position. But they obviously eventually merge. And then improved technological innovation, which might be driving demand as well. We'll capture that with some time trends, time fixed effects, and we'll also control for income. But I just want to point out, especially for someone that is interested in equity, and also as an infectious disease doctor, I think we're very drawn to the patient's medical history and also just the history of how, the profession. This is how the AMA kind of viewed the world. This is their concept on medical economics. And so my new understanding of medical economics and health economics in general is really that it's was created by the AMA, and this was their way of dividing the US population. So here you have income levels on the y-axis and different types of illness on the x-axis. And so you have minor and major illness, chronic illness, institutional care that could be either mental health or sexually transmitted infections or communicable disease like TB. And then you have prevention. And then indigent all the way up to, these would be above the median income in the early 1940s. So, wealthy people, there's really no role for an insurance product in this world. It's concierge, it's fee-for-service medicine, right? You don't need insurance if you're wealthy. If you're indigent sick, you're community responsibility. Again, kind of harkening back to that Elizabethan poor law type of thing. And for prevention and for mental health and communicable disease, these are also to be coordinated by existing sort of volunteer agencies, nonprofit religious authorities. And obviously, if you're kind of someone that works in public health or infectious disease today, you kind of feel the legacy of this, perhaps. Who is insurance for? Insurance is for middle-income Americans for acute and major illnesses. For acute and major illnesses where medical therapy can provide some sort of treatment. And so I think that's very interesting because already, they're excluding people that can't pay. That obviously includes a lot of women who might not have been employed in the formal sector. It includes a lot of individuals, people of color who couldn't afford this product from the get-go. So the equity considerations are kind of already kind of built into the system. And I just thought that was interesting given the discussions that we've been having today. So I want to be mindful of time. I'll just say that I think, this was a huge, massive data project. We can show you some of the stuff that we were able to get. These are the receipts. Like, it's nice to be able to say we have the receipts, but we actually have the receipts. This is the advertising company, Lockwood Shackelford, that Whitaker Baxter used. You can see that they're billing the AMA, and we know where and when they're putting these advertising. We can actually also know which physicians are AMA members. So sometimes the data are really good if you go back in time. So these are individual entries from the American Medical Directory. If the name is capitalized, you know that person was an AMA member, you know their birth date, you know where they work, and you know their various specialties. So we digitize that. We can also digitize the entire newspaper directory. We can know if it's got a Republican or Democratic or nonpartisan leaning. We can know features of the municipality or town that it's publishing in, and importantly, we can verify the circulation numbers. And then this was very exciting. We actually were able to find, this is actually an AMA publication, features of the very early private health insurance plans that the physician societies either approved or created themselves. So these always had special enabling legislation that allowed them to operate on the state level. So it's still today, you have Blue Cross Blue Shield of Massachusetts, of Georgia, of California, et cetera, because they had special legislation that allowed them to start right away with very little capital reserves. But the most important thing is that we can pull the enrollment numbers here, and you can see some of the exclusions. Oftentimes, the usual exclusions included babies. Newborns were considered high risk, adversely selected, as were pregnant women, unless you were married and got pregnant after 10 months of enrollment. So that's really kind of neat. And the very last thing that we have that I think, if we have time, I'll get to, is when it was the Eisenhower election. That's the first time the Republican Party really espoused this idea of voluntary or private health insurance for the majority of Americans. And so there was the first, as we know of, or at least one of the first PACs, what's known as political action campaigns, and the physicians. This was the National Professional Committee for Eisenhower for president. Who was Whitaker and Baxter were again the chair and executive director, and actually an outgoing AMA president was the president of that association. So we digitized and then linked all of the donations to the doctors and looked at how much the campaign they were exposed to as well. Okay. So maybe in the interest of time, I won't go over the conceptual and empirical framework. This is more for my economic audience. I will just say this, though. There was not just this messaging coming out. So I don't want the audience to leave with the idea that this was just one narrative. There wasn't. But I will say, if you think about advocates sending messages to the voter, right, and then the voter updating and providing messages to the legislator, I will say that that the private sector was able to move had many more resources at its disposal. So we compute $250 million in current terms, so $250 million to spend on this campaign, versus what the public sector was able to muster, along with a nonprofit run by the Rosenwald Foundation, the Committee for the Nation's Health, about $1 million. And if I could show you the pamphlets that the public sector was putting out, it was vastly different. It was like a very kind of cerebral, rational, not emotional persuasion, but very rational. The AMA was for national health insurance just a few decades ago. The AMA is what we would call a monopoly, trying to explain what a monopoly is to the American public. And then there was the Taft-Hartley Act, which really hamstrung the unions in terms of the amount of advocacy and organizing they could have done around this issue. So that really meant it wasn't like there was no other voices of the day, but I think they were, it was just really lopsided in that regard. The other thing that the private sector could do, though, very smartly, was not only could they influence, what is the state of the world, what will actually bring the American public, more additional, what's the highest net welfare for the American public, and kind of convince them that they had this quote that they attributed to Lenin, which is like the national health insurance or compulsory health insurance is the keystone to the socialist state. Nobody's really been able to locate that quote, ascribe that quote directly to Lenin, but interestingly, it did show up when in editorials in the Wall Street Journal against, for example, the Obamacare. So they had this I as a subscript of S is like their ability to influence the state of the world, but then by providing a private alternative, that was really smart, because they were able to move really quickly and kind of reduce demand for a public option, particularly among, again, middle class voters at the time. Okay, so this is our conceptual framework. The private advocate, AMA, Whitaker, and Baxter, building out this campaign of pamphlets, mass advertising that includes ads through newspaper readers, and pamphlets being distributed through doctors. So, we've got to figure out a way, to combine all of this into like a single exposure variable. So we did what we thought was most natural. We've tried different functional forms, but we essentially added the two. So we added the MD component and the advertising component together. And like I said, you can look at these individually, but really it was one highly coordinated, very sort of very quickly deployed campaign. And so that this was our first instinct was to combine them. And so we're basically taking, for the MD component, it's the per capita pamphlets, those pamphlets that we saw, shipments of to the medical societies, and then that's being distributed by whatever share of your physician workforce is AMA affiliated in your area. And then for the mass advertising component, we have the campaign ads per population, and that's being distributed by is our proxy for newspaper readers, which would be people with a high school education or above at the time. So we're going to standardize both components so that we can read this whole thing out in terms of standard deviation units. As I mentioned before, this is, there are other things that we know influenced the exposure or the demand for national or private health insurance, rather, like income, if it's a normal good. So we'll include income as a design control. Unions would be an obvious place to try and sell this product. So unions are going to be a design control. And then, but to be fair, I really think that there would have been very little rationale for trying to target these ads or this campaign in any meaningful way. First of all, the private health insurance market was essentially obsolete. So they had large scope for selling this product. It was not a crowded market by any means. And the second thing, of course, is that they were really under duress. So they were using they were using the networks that they knew, which was an advertiser, Lockwood Shackelford, that they kind of had partnered with in the past, Whitaker and Baxter, and also they were using the membership of the AMA. But one way we do this, this is kind of the economist equivalent of a balance table, like you would see in an RCT, as we just look at whether our exposure variable predicts the outcomes or other variables of interest in the pre-campaign period. So if we really are thinking that this is randomly assigned, conditional on income and unionization, we shouldn't see that that we're actually predicting anything before the campaign starts in 1948. And that is typically the case, with the exception of slight negative correlation with whatever the share of Black is in your area, the share of Black Americans in a particular area, which probably is not a huge surprise. So we can go onward to the estimating equations. Again, this is just, like, because we don't have a simple randomized trial, we're just going to look at enrollment per capita on the left-hand side. We're going to look at campaign exposure on the right-hand side. That's probably all you need to take from this, except that we're going to use multivariable regression to adjust for time fixed effects, state fixed effects, and state year characteristics. And we're going to also look at individuals in the Gallup poll data to see whether individual respondents in those poll data support national health insurance. And we're going to actually we're going to be able to include individual level controls when we do that exercise. We'll also look at these public perception, these civic organization resolutions, and how many. This is just a cross section because there's no resolutions prior to this time. And then finally, we'll look at how close the congressional language is to the campaign exposure. And we'll look at that based on whether or not the congressperson is a Democrat or a Republican. So we'll break it out by Democratic and Republican. Okay, I'm going to go a little faster. So all of that data basically comes down to this one plot where we're looking at the difference between the share enrolled in health insurance, in private health insurance, these Blue Shield plans, prior to the campaign, which is 1946, 1947, going up to 1948. And then the gray is during the campaign. And then we stop, importantly, in 1954 for two reasons. Number one, we stop in 1954 because the tax law changes. And I don't think it changes because of some random event. It changes because this is now becoming a very common way for people to get their health insurance. And the writing is on the wall. Eisenhower is now in office. And so the tax law changes to reflect that. The second reason is our data are from the AMA, from Blue Cross Blue Shield plans. We can't see corporate plans, which really start to take off after the tax law changes, because the Doctors Society plans, sponsored plans, are kind of flush with money. And so there's obviously going to be entry from private firms. And so our data just would not cover the universe at this time. So this is kind of what we see, is that there's this immediate bump up in enrollment of about 2 to 3 percentage points across the entire American public. If you limited that to sort of white employed males, you would get an estimate that's 3 or 4 times as high. And you can see that this 3 percentage point mean in the pre-period suggests that there was almost no private medical insurance prior to this campaign. So these plans existed. The medical societies had developed them in response to state-sponsored legislative threats as they perceived them. But there was very few people enrolled. 10 percentage point increase over the entire 1948 to 1954 period on average, and it's about a quarter of that is related to exposure to this campaign. So that's our number one finding, that this campaign had real effects on how people enrolled in these private plans. What about approval of national health insurance legislation? So we don't have a lot of pre-data. This is one of the things when working with public opinion data, you only have it when it's hot. And so you'll see it actually goes away after 1950. And that's because it literally goes away. It's off the agenda. But you can see that it's, if anything, if you kind of zoom out, if anything, growth for public health insurance is growing. If there's a pre-trend at all, it's going in the opposite direction. But then it kind of takes this hard turn. And this is what I mentioned before, about 68% of Americans approved of or supported the legislation in Congress, but then that changed. On average, it changed quite a lot. And it changed if you were exposed, one standard deviation increase in exposure to this campaign led to a drop in support for national health insurance by about 6 to 8 percentage points, depending on the specification. The specification changes a little bit as we move across the columns. So now we can look at heterogeneity in the Gallup data because we do have individual characteristics. So who was most primed or moved by these by this sort of messaging? Interestingly, it wasn't unions or males or those who have a phone, which was our proxy for higher income, but it was really those who had previously voted Republican were most responsive, and those who lived in urban areas presumably had better access to some of these hospitals, amenities, and exposure as well. We also see that civic organizations that were exposed to this campaign were much more likely, this is 4 per 1,000 population, were much more likely to actually pass these resolutions for public health insurance, for private health insurance or voluntary health insurance at this time. And then this is, again, just descriptive. So, one of the things you can do with the congressional record, which is completely digitized, is you can look back at this time period, and you can see that unemployment insurance was talked a bit about, in the 1940s to the late 1940s, but nowhere nearly as commonly as health insurance was talked about over this Congress that came in with Truman in 1949-1950 period. And the National Association of Manufacturers was talked a lot about when debating the Taft-Hartley Act and putting constraints on unions. And so the National Association of Manufacturers were talked a lot as like an interest group at this time. But again, nowhere nearly as prominently as the AMA. The AMA enters the congressional record a lot at this time period. This is what I mentioned before, that we see that the speech of especially, you can see more of these red boxes. These are Republicans. So the speech of Republicans is like shifting more towards the AMA propaganda. This is the last slide I have, and then I'll stop for questions. This is just showing us that when we compare, like I said, we don't have votes in Congress. This legislation never got out of committee. We don't see that the campaign affected mentions of health insurance or mentions of the AMA, but it does affect mentions of political medicine. Or so if you talk about insurance, do you describe it as political medicine? And are your words very similar to the AMA Whitaker-Baxter propaganda using this cosine similarity measure? That's where we do see movement, and it's particularly pronounced for Republicans versus Democrats. They seem to move in opposite directions. So that was our kind of whirlwind tour through the history of national health insurance, or our understanding of our revised understanding of why we do not have it. Is just that we kind of meaning our doctors, played a pivotal role in that moment in time. I think it's really hard once you have a private benefit for middle-class Americans. I think it's really hard to get rid of it. I think it took 20 years until 1965 with older people that were never covered in these plans to lose their employer-sponsored benefit, where we finally get Medicare. Thank you.
Thank you, Dr. Olson. That was an incredible review. And I think so helpful, one, just for all of the rich history that it offers us as we think about this topic, and also just the ability to contextualize some of what we've seen evolve in our own lifetimes and in health insurance and coverage. We are already getting some questions in the chat, not surprisingly. Dr. Seiberg wonders, what does public messaging on this topic look like now? Are there new considerations or motivations by advertisers in the setting of the COVID pandemic?
Yeah, and I really appreciate the opportunity. So if by any chance we run out of time, I will just put my email in the chat, and I would love to, you know, for me it's been a huge education. You can imagine. My slides were also saying that this was the strength of the unions, et cetera, 2 years ago. So anyway, just please feel free to email me anytime. And then I do want to, just because he was my attending that I forever and ever will, think of Dr. Del Rio. So I need to call I need to call on him at some point. But I will say, it has made me think of like, am I in a campaign right now? I don't even know. Like how I put myself in these position of these middle class Americans. How would they have ever known that these backroom deals, that these discussions were being held? And it's just, and I think that's actually one of the concerns when you have a lot of income inequality. And I think, I'm not at all the first or last person to mention this, but how it actually shapes public policy is incredibly interesting. And I think defending the quote unquote status quo is is something that doesn't actually really get enough attention in academics more broadly. Like things that don't happen, that's also an interesting question. Why don't things happen? and is it really just all inertia? Um, so so hopefully that kind of approximates an answer to that. Um, is it okay to see what Dr. Del Rio has
Yeah,
to
Dr.
say?
Del Rio,
Okay, and then I'll give you back the
comment.
moderating.
So, Marcy, thank you very much. That was great. So two issues, as you said, the population is aging, and I've always found it fascinating that, Americans hate government health insurance until they turn 65, and then they love government health insurance. Everybody says, don't mess with my Medicare, right? So do you think as population ages and more people are going into Medicare, there'll be more appetite for this? And the other thing is, I've always found it fascinating that because insurance is tied to employment, it actually frequently limits mobility of people. People have the inability to change jobs if they have a chronic condition because they worry about losing their insurance coverage. So it almost becomes something that at the same time, for employers is becoming an expense that is too high for them. So do you think all those economic forces will play into this?
I am not optimistic about sort of an evolutionary change in the current landscape. I think there's just too much money being made. It's incredibly, it's $5 trillion. And I know that's not going to many people on the Zoom room either. And so there's just a lot of money, that there's a lot of money involved, right? So I think the thing that is, what you described as job lock, I mean, it's never been a rational system. You would never tie risk of medical need to unemployment risk. You would never tie those two things together in any economic state of the world. So that is just, it was purely out of convenience, trying to find a healthy pool of people that you could easily obtain money from, where this product first came through these sickness funds, really going back all the way to some of the principle of solidarity in Bismarck in Germany. What do I think would overcome it? Well, now I'm speaking not as an academic, but I'm speaking extemporaneously. And I think physicians actually do need to be a part of it, because I think physicians are still trusted voices in this space. And I don't think our predecessors envisioned this world in which corporate interests and MBAs were deciding who gets care and who doesn't get care. One of the main motivations for doctors to organize in this way is because they wanted to keep the clinical decision-making power, right? And if that is eroding right and shifting right in front of us, then I think it's sort of incumbent upon us to be that voice. I think the second issue is, of course, the other interest group is all the other industries. 25% of our GDP is healthcare. That means a good chunk of it is not. And when are they going to say enough is enough? Because it's very, very expensive to hire workers when premiums keep on rising. And so that's the alliance that I think would actually I'm pretty I'm pretty I feel like you just need a bigger set of interest groups.
Sounds good. Thank you.
I have a dissertation defense to run to. Are we okay with that? Is that okay? Okay.
Absolutely.
And please call me anytime, Carlos. love to talk more. And I really appreciate you all listening. Happy New Year. Happy holidays, everyone.
Happy holidays, guys. Take care, Marcy.
Thanks for being here, y'all. Happy holidays and safe travels.